Chapter 50, Concepts of Care for Clients with Stomach Disorders. The priority concept for this chapter is immunity. The interrelated concepts for this chapter are nutrition and comfort. H. pylori, or Heliobacter pylori, is a gram-negative bacteria that penetrates the mucosal barrier. It is a major cause of peptic ulcer disease, which can lead to chronic gastritis. Non-steroidal anti-inflammatories, or NSAIDs, inhibit prostaglandin production. Prostaglandin helps to inhibit acid production and increases mucus production, which provides a protective layer on the mucosa. We had talked about radiation therapy when we were in the oncology section. Just remember that radiation therapy is going to cause local irritation. So if it's targeted at the GI tract, you're going to have irritation of the GI tract. Ingestion of corrosive materials, corrosive chemicals such as drain cleaner or lye, that's going to cause destruction of the stomach lining. For autoimmune disorders, the body is going to be attacking the parietal cells, and that decreases intrinsic factor, and this is usually found in type A gastritis. So health promotion and maintenance, this one is pretty cut and dry. So you want to make sure that you are ingesting a balanced diet. You have regular exercise, stress reduction strategies and techniques, and you're going to limit foods and spices that cause gastric distress. And this is going to be a little bit different for everybody. Tobacco and alcohol are also going to cause problems here, and excessive use of aspirin and NSAIDs. So you want to assess your patients for nausea and vomiting. If they do vomit, you're going to assess the vomit itself. You want to make sure that it doesn't contain any blood. And the name for that, for vomiting up blood, is called hemoptysis. You also want to be completing a full pain assessment on these clients. So the presence of pain, not just the number scale of 0 to 10. We want to know what type of pain, what the duration is, what makes it better, what makes it worse, the quality, ask if it's stabbing, aching, cramping, that kind of thing. So we want to do a full pain assessment. And ask them if they have any heartburn, if there are any foods that trigger that. We just want to make sure we get a comprehensive assessment here. And to ask them if they have any melena or blood in their stool. For diagnostics, the first one we're going to talk about is the esophagogastroduodenoscopy, or EGD. If you have a hard time saying that word, when you're looking at it, just break it down by syllables, and it's actually pronounced exactly how it's written. The EGD is going to be the best way to diagnose gastritis. This is performed under anesthesia, so the patient will be asleep or in twilight sleep for this procedure, so they will need to have somebody drive them home from the procedure. There is a prep associated with this, and different physicians prep different ways. Some of them will have them have like a clear liquid diet a couple days before. Some won't do that, and they'll just skip right to NPO at midnight. It just kind of depends on the doctor's preferences. So you're going to follow the guidelines for prepping the patient. They're going to be under generalized sedation, so they're going to be asleep. They won't remember it. And the physician, the provider, is going to take a camera, a scope, and they're going to enter in through the mouth, and they're going to make their way down through the esophagus and into the stomach. And they'll actually be able to take a biopsy while they're down there. So they're going to look at the esophagus and the stomach itself. If a biopsy is taken, they will take that over to pathology for an examination, and that way they can rule out any cancer. They can also take a tissue sample to rule out the H. pylori. And the H. pylori test comes back pretty quickly. And this right here, the rapid urease testing, that is the test for the H. pylori. Gastritis is an inflammation of the gastric mucosa, that is the stomach lining. So erosive gastritis is going to be causing ulcers, that can cause ulcers. Non-erosive gastritis, there's going to be no ulcers, but you're going to have that pain, the burning, and the nausea. With acute gastritis, the appearance is thickened and reddened, and the mucous membranes have the rugae. So that's going to be the folds, and this typically resolves within a few days. With chronic, that is going to appear as a patchy or scattered inflammation. And as this progresses, the stomach lining will begin to thin and atrophy, kind of like when you're not using a muscle. So stomach is a muscle, it also atrophies. And the secretion of the intrinsic factor from the parietal cells is also going to be lost. So this results in a decreased absorption of vitamin B12, and you will see that with clients with pernicious anemia. This can last for a few months to a few years, just kind of depending, and it increases the risk of developing stomach cancer. There are 3 types here. So type A is not erosive. That's going to be an inflammation of the glands of the fundus and the body of the stomach. Type B is going to affect the glands of the antrum, but it can involve the entire stomach, and usually this is going to be caused by H. pylori. There's also a trophic, which is going to be diffuse inflammation and destruction of deeply located glands. This is going to involve all layers of the stomach and can lead to peptic ulcer disease and gastric cancer. The causes of these are going to be H. pylori, stress, caffeine, NSAIDs, alcohol, steroid use, ingestion of corrosive or toxic substances, bacteria, we already covered H. pylori, and of course smoking. For acute gastritis, it's going to be supportive care. We can provide medications that will coat the stomach like a GI cocktail. And this is an antacid with viscous lidocaine. So it's like a thicker type of lidocaine to help numb the area. If the burning is severe, sometimes they will also put them on an IV medication, octreotide or omeprazole, Protonix, that kind of thing. If there is bleeding, they will end up having to have a blood transfusion. So your client could need a blood transfusion. And then, of course, IV fluids to replace any that are lost during dehydration. And if it's extensive loss due to vomiting, they may need to have electrolyte replacement as well. And then with chronic, it's really going to vary depending on the cause. So the fastest way to treat chronic gastritis is to eliminate the trigger for it. So whatever's causing this problem to occur, like if it's underlying disease, they mentioned Crohn's disease here, so they would need to treat that, and avoidance of toxic substances. Peptic ulcer disease, you'll see that abbreviated PUD, so peptic ulcer disease. We've got a lesion in the stomach or duodenum, and this occurs when the mucosal defenses become impaired. So the epithelium is not protecting the cells from acid and pepsin. So we've got a breakdown in the lining. So this illustration depicts the conditions that favor the different type of peptic ulcers that are out there. So on this one, we have conditions favoring the gastric ulcers. So we've got normal acid production that's occurring, but a lot of times we have delayed emptying with these patients. You might see them have gastroparesis or something else might be going on with them. So the stomach acid is maintaining contact with the stomach lining for extended periods of time. And then duodenal is a little bit different. We've got increased secretion of gastric acid here and an increase in stomach emptying. So with gastric ulcers, you're looking at development typically in the antrum, so right in this location right here. And if you can imagine, if we have this injury located here, the hydrochloric acid is going to come into the stomach and it's going to really cause injury to that epithelium. Sometimes this is caused by reflux. So we've got the pyloric sphincter here, so we can have reflux through that sphincter, or we could even have a hypersecretion of acid. And that's going to result in further ulceration. So we're going to be really irritating this point of injury. For stress, stress ulcers really aren't that common, although nursing students would probably disagree with you. A lot of people would probably disagree with you. Just not very common. Usually we see them with hospitalized clients, and it's because they're under acute medical crisis. So something else is going on with them. A lot of times we try to prevent that by placing the patient on IV medication, like Protonix is a good one that they will administer that IV as a preventative measure. The generic name for Protonix is going to be the pantoprazole, and that is a proton pump inhibitor, a PPI. So again, the stress ulcers typically occur during a medical crisis. They can be trauma related, and they are sometimes located in the proximal duodenum. Hemorrhage is going to be more common with gastric ulcers, and perforation can occur if left untreated. So we're trying to prevent that from occurring. If a client does perforate, that can lead to peritonitis and sepsis, and that's going to be due to a leakage of contents into the peritoneal cavity. Pyloric obstruction is pretty rare, and it's generally caused by scarring and fibrosis at the pyloric junction. For etiology, we have H. pylori again. That's going to probably make a comeback several times when we are discussing GI. NSAIDs again, so we want to really educate our clients on the use of NSAIDs, and then other substances that alter gastric secretions. And there's a lot of examples here. So this is where we're going to be assessing for risk factors. You want to ask your client if they have any history of H. pylori, or if this has happened to them before, any GI surgeries, because that's a stress factor right there, and any prescription and over-the-counter medications. And don't forget about herbals. Always remember herbals, because there's so many out there and they come out with new ones all the time. So make sure that you're asking. And then while you're obtaining a history, make sure that you're covering their dietary habits. So ask them what they typically eat, if they smoke, if they use tobacco. Make sure that you're covering that, and not just what they eat, what they drink as well. So when you're performing your physical assessment, we always want to make sure that we're covering pain, and we want to get a thorough pain assessment performed on these clients, not just the scale of 0 to 10. We want to know what makes their pain better, what makes their pain worse. So with peptic ulcer disease, they may have pain in the epigastric area, like the midline, and it could be aggravated by food. So this is going to happen after they eat. About 30 to 60 minutes later, they're going to have their pain. So when you're questioning them about that, ask them what time they ate, and then what time the pain occurred and what they ate. If it's a duodenal ulcer, the pain may appear in the upper portion of the duodenum, and that occurs 90 minutes to 3 hours later, which makes sense because the food takes a while to get down to that area. So that pain is going to be generally located in the right of the epigastrum. Dyspepsia, they're going to have indigestion. That's going to be common with these clients. They will sometimes report a feeling of abdominal fullness or bloating. They might feel like they can't get any relief, depending on the position that they're in. And they may also have some nausea and vomiting. If that occurs, you really want to assess your client for fluid volume deficit. So remember what we talked about with the fluid and electrolyte section on what's involved with that. They may also have electrolyte imbalances depending on how significant the vomiting is. So along with that, you're going to remember that when you're coming up with your diagnoses, your nursing diagnoses for them and your interventions, these clients may feel dizzy or lightheaded because of the lack of hydration. So you want to make sure that you're checking for them for orthostatic blood pressure. So make sure that you're checking that. They need to be educated to, when they get up from a laying position, to rise up slowly and just to be cautious with ambulation. With rigidity, if your client has a suspected perforation or a perforation has occurred, one of the early assessment findings would be a rigid abdomen. So it would be a board-like abdomen. And your client may also assume like a fetal position. So their legs are going to be drawn up. They could be laying on their side. And that's in an effort on their part to decrease the tension on the abdominal muscles because it's really quite painful. One of the things that we can do to help them when they're in a bed is to raise up the knees and raise the head of the bed to take the stress off the abdomen. And really this is a medical emergency. So if perforation occurs, if you have rigidity, that is an emergency and that can lead to sepsis within a very short period of time. So it really requires immediate medical intervention, immediate surgical intervention. And then with their bowel sounds, if they have peritonitis, initially they might be hyperactive, and then it's going to be progressing to diminished or even absent. I really want to stress to you that these are really significant assessment findings, and we should be moving quickly when this occurs. So if your patient has rigidity, hyperactive bowel sounds, and it's, or even if it's progressed to absent, that we need to be notifying the provider immediately. For diagnostics, we can test for H. pylori again, and you don't necessarily have to have a biopsy for that. You can use a urea breath test, so it's non-invasive, and you're checking for the byproducts of the H. pylori itself. And you can also check the stool for H. pylori antigens. If you suspect perforation, you can get an x-ray for this, so a chest x-ray and abdominal x-ray to rule that out. But for general diagnostics, you can just end up doing the EGD again. And we had discussed the EGD before. So EGD, H. pylori, if you suspect perforation, get that x-ray of the chest and abdomen. The one of the abdomen they refer to as a KUB, or kidneys, ureter, bladder. Also, if your client has been vomiting, like a lot of vomiting with this, make sure that you're checking their electrolytes. So a CMP. If you suspect bleeding, we want to check the CBC to make sure that they don't need any further interventions. And then they can also do a med test called a tagged RBC scan. So a tagged RBC scan, they'll take a little bit of blood from the client, they'll tag it with some type of radioactive nucleotide, and then they'll put it back into the client, and then they'll scan them periodically to see if they can locate where that bleeding is happening. So a couple different ways we can help manage this. The main purpose of drug therapy, of course, is going to be pain management and treatment of the H. pylori. And then we want to encourage healing and the prevention of occurrence. If they're having acute pain, we can administer a GI cocktail here again, or even some antacid, some calcium carbonate or Tums, or some Pepto, and that's going to help to reduce the dyspepsia or discomfort that they're experiencing. If the client is being treated for H. pylori, we're typically going to use a PPI, a proton pump inhibitor, plus 2 antibiotics for that. And that's usually going to be metronidazole or amoxicillin or even clarithromycin. H2 receptor agonists, those are going to be your Pepcid and your Zantac, and those are typically going to be prescribed for about 4 to 6 weeks in combination with other medication regimens. Then we have Carafate, sucralfate, Carafate. That's going to be a medication that creates a barrier, so it kind of is coating that mucosa layer, and that helps to prevent damage. Nutritional therapies, we would want to include a bland diet. This is going to be one of the things that's going to be one of the more challenging items for the client to have a dietary change. And then there's also complementary therapies such as stress reduction and medication to manage stress. If your client is experiencing bleeding, there's a couple different ways to manage that. So they may try to manage that with medications like octreotide, because that will help heal the gastric mucosa, or even pantoprazole. They can give that IV drip. They might end up having to insert a nasal gastric tube, especially if your client is having some vomiting, because blood is an irritant and can cause you to be nauseous. So they could do gastric lavage and rinse that out. So a couple different ways there to take care of that. If it progresses, your patient could end up needing to undergo anesthesia. So on the more mild end, they could end up with just an EGD, where they go down with the camera and they possibly cauterize the area or clip it even. So they have these little clips they can use to clip the site of bleeding. And then there's a couple other things they can do, and that includes a subtotal gastrectomy pyeloplasty, and that's where they're going to open up the pylorus, or they could even do a vagotomy, and that's going to be to suppress acid secretion. But they're going to try to do the non-invasive ones first if possible, if it's feasible to do so. The goal with these clients is to provide education to prevent complications, or to prevent further complications. We want to make sure that we're helping to control their pain and educating them on their diet, or even positioning in the bed to help promote relief while they're trying to sleep. We want them to adhere to the drug regimen and to lifestyle changes. And again, that's going to be the more challenging one for them, especially if they've ate that way their whole life. And we want to really avoid GI bleed. So that's our ultimate goal right there. So with stomach cancer, we generally have adenocarcinomas, and a lot of times these are asymptomatic until it's pretty far advanced. Your client may not have any symptoms until they're in further stages of cancer. So for etiology, H. pylori is going to be a significant risk factor here. And when I had mentioned pernicious anemia before, that is also a risk factor for developing stomach cancer, as well as gastric polyps. That's something they could identify on an EGD. Chronic atrophic gastritis also can be identified on an EGD as well. And then, of course, diet, eating pickled foods, nitrates from processed foods. That's going to be like your hot dogs and your lunch meats, those kind of things. Oh, and I skipped over this one. So that's going to be referring to the absence of hydrochloric acid secretion. So people that suffer from that generally are about 2 times more likely to develop cancer. Back to foods. I think we covered this one. So pickled foods, nitrates, that's going to be your hot dogs, your lunch meats, those kind of things. And then salt. So, and when I say salt, I don't mean like your average amount of salt that exists in your food already. Processed foods typically have a lot of salt, and then people tend to add more salt to it. So that's what I'm referring to, not the naturally occurring amounts. And then any type of prior gastric surgery is also going to increase the risk factors, because those clients that have undergone the knife and had gastric surgery typically have development of atrophic gastritis, which we've already discussed. With incidence and prevalence, this is going to be more common in males than in females, especially those that are over the age of 50. And then in the United States, the ones that are going to be, the population's going to be at risk are going to be your Hispanic Americans, African Americans, and Asian Pacific Islanders. They all have a higher incidence of development of gastric cancers. For health promotion and maintenance, we want them to follow their regimen closely. So follow-up appointments are going to be important with that to maintain compliance. Eat a well-balanced diet, limit pickled, processed, and salted foods, and then avoid alcohol and tobacco. So not just smoking, all tobacco. So again, we're going to do a thorough history for these clients. We're going to ask them about their diet history, if they've ever had H. pylori, if they've been treated for it, any gastric surgery or polyps. And then we're going to ask about their signs and symptoms. So are they experiencing dyspepsia? That's the indigestion, a feeling of fullness, abdominal discomfort. These are all going to be common early symptoms. And a lot of times we tend to ignore those because indigestion is a very common symptom of a lot of things. So that's why a lot of times these cancers go unnoticed until they're pretty far advanced. And then we're going to assess for anemia. So we're going to make sure that client has a CBC ordered, so that we're checking on that. Checking for weight loss, so we're going to be weighing them. Nausea and vomiting are going to be present in advanced gastric cancer as well. So if they're going to be experiencing nausea and vomiting, we want to make sure that we're also ordering electrolyte panels, so a CMP in addition to that CBC, to make sure that they don't have any electrolyte imbalances. EGD, we've covered that, so we're taking a scope and we're looking inside the stomach. EUS, this is endoscopic ultrasound, so it's really combining two different types of technologies where they're using an endoscopic procedure to go down with an ultrasound, and they're taking a look that way. That way they can get pictures of the internal organs. CT, so PET scan we've discussed in oncology, so they could scan them for metastasis because that's really what they're looking for there. And then, of course, the MRI. For clients with extensive gastric cancer, they may undergo a total gastrectomy, and they are going to be removing the stomach. So this whole part of the stomach is going to be removed. And then the anastomosis, and that's where anastomosis means like a connection. So they're connecting one spot to another. So here we have the esophagus being connected to the jejunum, and that's called an anastomosis. So pre-op care for a gastrectomy focuses on client teaching. So I always like to let them know beforehand what to expect. These clients are going to have an NG tube in place, and that is to prevent GI distension. They're going to be NPO, and they're going to take measures to prevent post-op complications such as atelectasis, monitor for an ileus or peritonitis. So consider what your interventions, what your symptoms would be. So you're going to have increased pain, distension. They could have hypoactive bowel sounds or even absent, increased temperature, increased WBC. And then we really need to be teaching the client about dumping syndrome so that they can avoid triggers for that. And if you're not sure what dumping syndrome is, it's when the body has a rapid emptying of food into the small intestines. So it causes a lot of distension, and it usually results in a bowel movement pretty quickly, usually at about 30 minutes of eating. So pretty quickly after eating. So typically, if that does happen with your client, they will have some vertigo, some tachycardia, and possibly some palpitations. they get a little diaphoretic, they get confused, they go pale. So we want to encourage them to rest for about 30 minutes after meals and monitor for signs and symptoms of this. We also want to provide education for them to eat smaller meals, eliminate liquids during meals, and eat a high protein, high fat, low carb diet. Going back to the immediate post-op phase, we want to make sure that we're managing that NG tube properly. So make sure that it's not occluded. Make sure that you're assessing for placement. And then if your client is experiencing nausea, and especially if they're experiencing any type of vomiting, we need to make sure that we're checking that NG tube for patency. And not all clients are going to have a total gastrectomy. It could be a partial as well, but a lot of the post-op interventions are going to be the same for either type of surgery. If your client is not a candidate for a gastrectomy or a partial gastrectomy, they may be managed with chemo and radiation. So just refer to the information we covered in the oncology section for that. That is actually your last slide. You do have some review questions, so make sure that you download these PowerPoints. And that concludes Chapter 50, Concepts of Care for Clients with Stomach Disorders.